Hello, and welcome to this Lupus Forum webinar on early use of advanced therapies in lupus. This is a subject that's been coming up more and more in our discussions in the other podcasts that we do. So this is our chance to give it a little bit more attention, to take a deeper discussion about some of the concepts involved. So this webinar was supported by BMS with an unrestricted grant, but BMS didn't have any influence on the content of these presentations. That was all decided by our speakers. And now let me introduce our speakers. So my name is Ed Vitale. I'm a professor in translational medicine and an honorary consultant rheumatologist at the University of Leeds in the UK. And I'm joined today by Dr. Guillermo Pons-Estel, who's the director of the research unit of the Argentine Society of Rheumatology and a consultant at the Centro Regional de Enfermedades Autoinmunes y Reumáticas. I think I'm getting better at saying that. I'm also joined by Professor Richard Furie, who's the Chief of Division of Rheumatology at the Department of Medicine at Northwell Health in New York, and Professor Chris Edwards, who's a consultant rheumatologist and honorary chair of clinical rheumatology at University Hospitals, Southampton. Hello, everyone.
Hello, Ed.
Hello, Ed.
So, on to the housekeeping. So, the attendees, you're all on mute for the duration of the meeting, but although you're muted, we do want to hear from you. We would want to hear your questions, which you can enter into the Q&A window. If you enter those as we go along, at the end, we'll go through all of those and we'll try to get through as many of those as we can. And also at the end of the webinar, we'd appreciate it if you could just spare a few minutes to give us some feedback, because we do always look at that to help us decide what to cover next time. So on to the content. So the learning objectives of this webinar, we're going to look at what are the limitations of standard of care therapy, where traditional therapies fail to achieve sustained disease control and how that might lead to poor outcomes and organ damage. Then we'll look at the opportunities to study early therapy of lupus in clinical trials or using existing trials. And then we'll look at strategic early intervention of advanced therapies, including using biomarkers or patient-specific factors to identify the candidates for early therapy initiation and more tailored and effective treatment strategies. So we're coming to the end of the introduction. So I'll first hand over to Guillermo, who's going to talk on that first theme about the limitations of standard of care therapy. And then I'll hand over to Professor Furie, who can tell us about what we can already tell from lupus trials and what we might learn in the future from those. And lastly, Chris will have a look at how we might intervene with advanced therapies at the moment. And at the end of all of that is when we'll go through all of the Q&A that we can. So without further ado, that's my chance to hand over to Guillermo for his first presentation.
Well, thank you, Ed, for the presentation. And the objective of my talk is to talk about the limitation of the standard of care. So these are my disclosures. And to set the stage of what we are going to talk, first, we need to understand that there's no standard or unified definition about what is the standard of care in the literature. There are several guidelines who propose a definition for standard of care. First, here, let me introduce the one from the GLADEL and Latin American Study Group of Lupus, that was defined as the use of hydroxychloroquine and if clinically indicated, low dose of steroids using 7.5 milligrams or equivalent in this guideline. Then EULAR and ACR presented late this year in 2024 their guidelines, and they use more or less the same construction for the definition of a standard of care that in EULAR was the use of hydroxychloroquine and even a lower dose of steroids using 5 or less than 5 milligrams per day of the use of steroids. Same definition was published by the American College of Rheumatology, that the standard of care for this patient, and that most of our patients should be treated with hydroxychloroquine, and if possible with the lowest dose of glucocorticoids. So what have we seen in the clinical trials, in the context of the clinical trials? So the belimumab and anifrolumab trials have defined the standard of care as a stable treatment with at least one of the following: antimalarials, glucocorticoids, and the use of immunosuppressive drugs. Both of these clinical trials have used this definition. Then, if we move over to lupus nephritis and the BLISS-ALEN trial, the standard of care in this definition was even further. The use of immunosuppressors was introduced with the use of mycophenolate or cyclophosphamide in an Euro-lupus regimen, with the use of azathioprine as part of the standard of care treatment in this trial. But these treatments are not without limitations. We know that antimalarials are effective to control disease activity, to reduce flares, to prevent damage, and to reduce mortality. But two significant limitations are worth mentioning about the use of the antimalarial drugs. First, that although they're relatively safe, as we know, and we use it in most of our patients, there are side effects that usually are related to the short term, such as gastrointestinal side effects or skin manifestations, or long-term cumulative doses with the side effects such as the retinal toxicity. But also in our population, and as we treat patients with lupus and they get older, it's also worth mentioning that we need to start asking ourselves if we are going to use hydroxychloroquine for everyone and forever. That's probably some of the other manifestations related to the use of antimalarials. Also, glucocorticoids had limitations. We know that they are truly effective to control disease flares and to control activity. But as is shown in this study by Marcelo Piga, on the right side, we can see that early damage is highly associated with disease activity and late damage to the use of glucocorticoids. But even when they look further in this Italian cohort, they saw that within the first year since diagnosis and treatment of these patients, almost 22% of the patients have damage greater than 1, and that this is highly associated with the cumulative dose of glucocorticoids. Moreover, we know that with high doses of steroids, such as 30 milligrams per day, we can see a vascular necrosis, psychosis in patients with lupus, and even with lower doses, such as 7.5 milligrams, we may see cataracts, risk of infection, and cardiovascular disease. Also, with low dose of steroids, we may be able to see Cushing syndrome, osteoporosis, and hyperglycemia, showing that even with low dose of these medications, we are ending with side effects in lupus patients. In a study by the French group, they asked themselves the question, and so it's possible to try to stop the use of glucocorticoids in patients with lupus. And what they saw in these clinical trials is that patients who maintain with glucocorticoids tend to develop less damage overall, and also on less flares. And also, as it can be seen in the picture of the left side, that there was a statistically significant greater probability of developing a flare in those patients who withdraw the use of prednisone compared to those who maintain a low dose of steroids. Now, jumping to the other part of the standard of care, that is the immunosuppressive drugs, we know that the immunosuppressants have led to better outcomes in patients with lupus, but they are also associated with side effects. Also, some of these medication has slow response rates. They may have a different type of side effects such as diarrhea, hepatotoxicity, and some of these medications tend to develop infertility and teratogenity in some of the patients, giving suboptimal responses in some of the patients, giving and showing some of the limitations of the use of the immunosuppressants. In the study from Margarita Sen, from the Italian group, they saw that when 1,105 patients who discontinue immunosuppressants due to remission, almost 25% of these patients flare after a median follow-up of almost 5 years. And when they look at the predictors against flare, they saw that the strongest predictor against the use of development of a flare was the use of hydroxychloroquine, again, part of the standard of care that we are using. So what is the objective of the standard of care? So the objective of the standard of care could be the definition of DORIS and remission. We know that in the DORIS definition, remission is associated with a clinical SLEDAI of 0 and a PGA of less than 0.5, but we can define DORIS definition on therapy and off therapy according to the treatment. On therapy is defined as less than 5 milligrams per day with the use of stable hydroxychloroquine or chloroquine, immunosuppressants, and biologics. And it could also be defined as remission of therapy when we are not using glucocorticoids, immunosuppressants, and biologics, and antimalarials are permitted. And if this is not the objective, we know that low disease activity is also a good endpoint for our objective of treatment, and that the therapy is associated and is similar to remission on therapy, but with greater doses of steroids. So can we truly achieve this remission or this objective that we have with and without the standard of care? For this, our GLADEL cohort that was started in 1998 and studied until 2005, Manuel Ugarte studied what was the achievement of this remission. And as it can be seen in this study of more than 1,350 patients, at last visit, almost 76% of our patients were not optimally controlled with the standard of care. And when we look at remission on therapy, at last visit, only 10% of these patients achieve remission on therapy, and only 2% of these patients remission off therapy. And why this is important? Because achieving remission, it was highly associated with less new damage and less severe new damage in the GLADEL cohort. Again, and now looking at the more actual cohort that was the GLADEL 2.0 that started in 2018 and is being actively in follow-up patients with more than 1,800 patients, we can see that still with the treatment that we are using nowadays in this part of the world, we see that at baseline, 85% of our patients are active at the baseline visit. And during the follow-up, only 22% of the patients on remission of therapy and 14% of the patients on remission on therapy did not flare during the follow-up of this cohort at 5 years of follow-up. And why it's important to try to achieve remission of therapy? Because as it can be seen here in the survival curve, patients who achieve remission of therapy have, when compared to remission on therapy, have less probability of developing damage, or on the other side, seeing that they have a better free damage survival rate when compared to those patients who achieve remission, but they have to still be on treatment. Also, and it's important to try to achieve this early in the course of the disease, and this is important because, as could be seen here in this Spanish cohort, the RELECER cohort, remission and damage in this case is highly associated and appears early in the course of the disease. As it can be seen here, almost 31% of these patients achieve damage during the first years the first and the second year of the disease. So it's quite important to try to prevent early damage in patients with lupus. Moreover, in the study from Margarita Sen in the Padua cohort, they saw that early in the course of the disease, there's a high mortality rates in patients with lupus that can go in up to 26% per 10,000 persons per month, and that this mortality is even higher in elderly patients and in young patients. So it's important to try with our treatment to prevent this damage and this early mortality in patients with lupus. And this takes us to the need to try to innovate, to try to achieve the goals of remission or low disease activity. And part of this innovation comes from the T2T strategy. We know that this early strategy tries to achieve to ensure early standardized proactive control of the inflammation, spare the use of steroids and prevent damage, reduce physician variation, and enhance the adherence of the patients to the treatment. These strategies are part of the innovation that we can perform to try to achieve the goal in our patients. Moreover, we need to deal with delay in diagnosis. We know that delay in diagnosis is associated with uncontrolled inflammation. This can lead to irreversible organ damage, immune dysregulation, and this could reduce the effectiveness of subsequent therapies. So part of the innovation is that we need to try to reach the window of opportunity and be aware about early diagnosis of this disease, and this is highly associated also with education for physicians and for primary care physicians, and even in the pre-graduate school of medical school. Also, part of the innovation comes with this shifting of the paradigm that we use. As we said, the standard of care is the use of antimalarials plus steroids. In mild patients, we tend to upgrade the treatment in patients with moderate to severe disease with immunosuppressors or with biologics. And now it's time to change and to try to rethink about how we treat patients. And this comes together from the different guidelines, the ACR or the EULAR guidelines that propose that patients with moderate to severe disease and even patients with mild refractory disease should be treated early with the addition of antimalarials and steroids, with immunomodulating and immunosuppressive therapies, as well with biologic agents, with the objective to try to taper the use of steroids early and try to stop these medications as soon as possible. Also, there's part of the innovation comes from the advancing therapies, and more is going to be said in the next slides and in the next presentations, but novel therapies target to B cells in new pathways such as CD19, CAR T cells, BAF, CD18 or bispecific technology tend to achieve a deeper and more durable disease control, and this could help the standard of care to achieve the objectives that we have seen, such as remission or low disease activity. So in conclusion, the take-home messages from this part of the talk is that standard of care remains insufficient for many SLD patients, that remission of therapy, as we have seen in the GLADEL cohort and in many other cohorts, is infrequent in patients treated with standard of care, that this standard of care is associated with side effects and with an incomplete control of the disease and long-term damage, and that SLE care is shifting to an early target novel therapies for a better outcome of these patients. It's truly important that education promotes early diagnosis and together with improved access that ensure all patients can benefit from this new paradigm, advance the SLE therapy. So with that, thank you very much.
Thank you very much. That's a lovely overview. I think we get so used to treating patients in a certain way that it's always good to sort of step back and ask ourselves, how well does this really work? And thank you also for ending on a very good introduction to our next presentation, because the question is whether novel therapies and advanced therapies can improve on these outcomes. And with that, I'm going to hand over to Professor Richard Furie to tell us whether clinical trials can answer that question. Over to you.
Thanks, Ed, and thanks, Guillermo, for setting the stage for my talk. So the question that I am trying to answer, and I must say it was very challenging, can our current trial designs inform about the benefits of early use of advanced therapies? And I stress early is in there. So obviously, our advanced therapies have been effective. That's why they got approval. But the challenge here is, what about the benefits of early use? Now, I interpreted that question to mean, can we show, or have we shown, that long-term benefit has been derived in our short-term clinical trials? Remember, our clinical trials are 1 year, and some of the lupus nephritis trials, 2 years. And we don't discriminate against patients with long-standing lupus, nor do we enrich for patients with disease of recent onset. So we rely on surrogates. And so what we just heard and what we do know is that activity begets damage, and damage begets more damage. And damage is, in fact, linked to an increase in mortality. So I think we need to rely on these two, activity and damage, to try to prove the point that early intervention is beneficial for long term. And we'll start with this particular data set from the University of Toronto group. This was published about 5 years ago, and it proves the point that activity begets damage, and damage begets more damage. Here you see in 3 different colors characteristics of patients who are entering the University of Toronto cohort, and in blue at the top, the higher the SLEDAI score at entry, the more likely one was to develop damage or more damage over the course of the disease. And you see 1 year, and you can just look all the way to the right, at 5 years. So in fact, if your SLEDAI score was 10 or greater, 37% of the cohort increased their damage score. And in the middle, in yellow, prednisone dose. The higher the prednisone dose at entry into the cohort, the more likely to develop damage. And at the bottom in green was the damage score. And you can see those who entered with more damage than not, so greater than 1 at the very bottom, were more likely to develop more damage. That's why it's easy to say activity begets damage and damage begets more damage. And there's a link between damage and mortality. Here you see a meta-analysis that was published about 5 years ago. And the conclusion is on the right side of the slide, that a 34% increased risk of death for each 1 point increase in the damage score. And I must say, it's not hard to increase your damage score by 1 point. And remember, the SDI scores are generated either from the disease itself or from the medications used to treat the disease. So if we look at our clinical trial metrics, which metrics could inform whether early intervention is beneficial? And here are the candidates listed on this particular slide. As far as activity, it doesn't matter how you're measuring activity, SLEDAI, BILAG, SRI, BICLA. It's good to reduce disease activity. So it seemed very intuitive that if you reduce disease activity in the long run, and we're really talking about, remember, the typical patient with new onset lupus is 20 or 30 years old. So they have another 50, 60 years at least to go. So it seemed intuitive if you reduce disease activity, there's long-term benefit. Now let's go back to the belimumab phase 3 program. In the United States, belimumab got an approval in March of 2011. And I can't tell you how many calls I got because the SRI, the SLE responder index, did not resonate with clinicians. So what we did, and it was published a couple years later, was to combine the phase 3 data, BLISS 52 and BLISS 76, and stratified by the SRI response, agnostic to treatment assignments. So we didn't care whether they had received placebo or belimumab. We just wanted to correlate the SRI response with items that are used in everyday practice. And you see on the next slide, on the far right, two columns, SRI response versus SRI non-response. And in the far left in that column, again, metrics that we use in everyday practice. So for example, if you were an SRI responder, the severe flare rate was about 5-fold less than if you were a non-responder. You were more likely to reduce your prednisone if you were an SRI responder, and far less likely to have to increase the dose beyond 7.5 milligrams. And again, these are data from a 1-year trial. And then you can see at the very bottom, patient-reported outcomes. And then along came the disease state, LL-DOS and DARS we heard about. And if you achieve these disease states, low lupus low disease activity state, or DARS remission, there are a lot of benefits there that are long-term. So fewer flares, reduction in damage accrual, improvement in quality of life, less healthcare utilization, and the ultimate being a reduction in mortality risk. Now, less steroid use is there, but that's somewhat circular because that's part of the definition. So we have both the disease activity instruments as well as the disease activity state, showing or suggesting a long-term benefit. And in fact, there was analysis of those achieving LL-DOS or DARS remission in the anifrolumab phase 3 program, along with the extension called TULIP LTE. And you see on the far left, LL-DOS, the top line, which should be color, looks like it's a bit of a maroon color, and then the bottom line in gray, showing new trajectory of LL-DOS attainment. And at 1 year, you can see almost 40% of patients on anifrolumab achieved LL-DOS, far fewer on the placebo. And then it kind of levels off, maybe drops a little bit for the placebo group over the 3 years of the long-term extension. DARS remission is shown on the right. Obviously a more rigorous, a more stringent endpoint. And you can see shy of 20% of patients at 1 year achieved DARS remission if they were on anifrolumab, and it rose to about 30% over the course of the long-term extension. All right, damage. Damage is the name of the game for any condition. You want to prevent damage. And as I stressed before, the SDI, the damage index score, can reflect damage either from the underlying disease or damage inflicted by the use of our medications, especially steroids. But the problem with damage accrual, at least in analysis in our clinical trials, you don't see separation between the placebo or the standard of care group and the experimental drug because damage accrual rates are relatively slow. But we obviously have these metrics. I mentioned the damage index. And for lupus nephritis, we can rely on GFR or perhaps proteinuria, as I'll show you in just a little bit. So in order to learn about damage accrual in short-term trials of 1 year or maybe even 2 years, we need some kind of novel strategy. Now, if you go back to the belimumab phase 2 and actually the phase 3 program as well, there were long-term extensions. The long-term extension for phase 2, as I recall, went about 9 or 10 years. But they were open label, so there was no comparator. You had nothing to compare the damage accrual rate on belimumab to. Anyway, so a novel strategy was needed to learn about damage accrual in the belimumab open label phase 2 extension. Now for anifrolumab, it was a unique design of the extension. The extension was 3 years and it remained placebo controlled, except after re-randomization of the placebo arms in the TULIP 1 and TULIP 2 trials. There were only 54 patients at the very end of the 3 years of the extension who remained on placebo. So not enough patients to do a statistical comparison to learn about damage. So the novel approach was to do a comparison to the University of Toronto cohort, which has been a long-standing cohort. And you might say, yeah, but the patients in the belimumab or anifrolumab studies compared to the University of Toronto's, like comparing apples to oranges. Well, to make it apples to apples, propensity score matching was used, but still there are a lot of limitations to the data. They were done in different eras. I think in the more modern era, a much greater sensitivity to steroid taper and to the comorbidities. Also, a lot of selection bias in an open label extension or any extension, in that the patients who do well stay in the study. The patients who don't do well drop out of the study. But be that as it may, there was an analysis comparing the phase 2 belimumab study to patients in the University of Toronto. And here you see on the y-axis the percent of patients without organ damage. In blue, you see the standard of care Toronto cohort, and in yellow, those who received belimumab as part of the extension. And as far as the rates, they're very different. In fact, if you look at the very top, you'll see the hazard ratio is about 0.4, so meaning there's about 60% protection to this metric if one was on belimumab. For the hardcore numbers, you can drop down to the left-hand part of the slide, and you see the 5-year SDI change, at least the mean, in the standard of care group was 0.7, whereas for belimumab, it was just shy of 0.3. And a similar analysis was done with anifrolumab, but a 4-year evaluation, because you had the first year of the TULIP 1 and TULIP 2 studies, and then 3 years of extension. But here you see the graph is displayed a little bit differently. The y-axis represents the mean change in SDI from baseline, and you'll see the real-world standard of care at the end of the 4 years. The damage is 0.6 increase, and for anifrolumab, 0.16. And the numbers are repeated down on the left-hand side, so statistically different. Let's turn to lupus nephritis. What can we use as a surrogate for lupus nephritis long-term benefit? Well, there are two things. So one is proteinuria, the other is the eGFR. We've learned from several studies that early reduction in proteinuria, that is a reduction in proteinuria to less than 0.7 grams per day or 0.8 grams per day in yet another study at month 12 predicted a better long-term response. Better long-term response was defined by, in one study, a creatinine of less than 1 at 7 years. But I think probably what might be a better indicator of benefit, of long-term benefit, is what happens to GFR over time. And because most of our lupus nephritis trials have now gone on for 2 years, we can look at eGFR slope. And that was first done in the BLISS-LN trial, and we looked at eGFR slope between weeks 24 and week 104, and you see a very significant difference between those rates in the placebo group on the right and to the extreme right, what happened on belimumab or on drug. Now, voclosporin, the Aurora trial was just 1 year, but the extension remained placebo-controlled. So again, it afforded the ability to look at eGFR slope over time, and you can see for these comparisons between drugs, the interval that was examined may have been a little bit different. But be that as it may, in each case, there was greater loss or a more negative slope in the placebo group for these various drugs compared to the intervention with the experimental drug. And the most recent data were with obinutuzumab, the Nobility trial being the phase 2 trial, and Regency being the phase 3 trial. And you can see, again, the numbers favoring drug. So there's an attenuation of loss of GFR with each of these interventions. And again, that is the name of the game with lupus nephritis. I mean, as we sit here, me talking, you listening, we are all losing nephrons, maybe at a very slow rate, but for those with an added insult of lupus nephritis, the rate is accelerated. So we need to maintain our nephron mass and therefore try to present GFR loss. What can we learn about safety? Well, I'm showing you an abstract from the American College of Rheumatology just last month. And this is looking at all-cause mortality with belimumab versus traditional small molecule oral immunosuppressants. And the data were obtained from a multi-center EMR. You can see a lot of patients, 21,000 patients. There was propensity score weighting, and the results are expressed in hazard ratios. Belimumab favored over azathioprine, belimumab favored over mycophenolate, belimumab favored over methotrexate. It doesn't really necessarily address early intervention, but you could extrapolate and say, well, it's good to intervene with an advanced therapy, such as a biologic, to help reduce the mortality risk. Now, there's a lot we need to learn about this particular evaluation, this particular abstract, like what were the causes of mortality, and there are many other questions as well. Subgroup analyses. We do subgroup analyses. You have to remember in our studies, they're pretty much underpowered, but we love to look at them, and they are hypothesis generating. I'm showing you data from the phase 3 anifrolumab program, and I have circled in red the onset of disease, either in the pediatric age group or the adult age group. And you can look at the anifrolumab response or the placebo response in the pediatric onset of disease versus adult onset. And you can see much lower rates in onset of disease in the pediatric age group. And I certainly have learned this from my colleagues, from my pediatric rheumatologists, as we inherit their patients. Kids with lupus are sick, and maybe this is, again, is suggesting early intervention with an advanced therapy. And along the same lines, just show you subgroup analysis from the obinutuzumab Regency trial. And again, I have circled in red a history of lupus nephritis at baseline, those who were previously diagnosed versus those who were newly diagnosed. Now, it doesn't really speak necessarily to early intervention, except, again, you can extrapolate. For example, if you look at the response rate in the obinutuzumab group, for those who were previously diagnosed, their response rate was almost 10 percentage points less than those who were newly diagnosed. So it would just be, it would make common sense to intervene early and aggressively in patients. Now, why we saw the opposite pattern in the placebo group, I don't know, but this is probably one of the hazards of small subgroup analyses. So could we design a trial to determine whether early intervention is beneficial? And there is such a trial with belimumab. It's called Be Early. It's a phase 4 prospective open label trial. And the goal is to enroll 350 patients with early onset disease, less than 2 years since diagnosis. The endpoint is LL-DOS at week 52. Remember, this is open label. So basically, there will need to be historical controls. And let me just tell you about the deucravacitinib trial called Poetic. This is phase 3. And you can see the entry criteria on the far left. So rather typical design, enrolling patients with active disease, SLEDAI score of 6 or greater, BILAG A or 2Bs, and seropositivity. The rest of the design you can see. But if you look at the bottom of the slide, you can see the endpoints that we've been speaking about. The primary endpoint, the SRI, and I showed you some of the potential long-term benefits for those who are SRI responders. And if you drop down to the secondaries, lupus low disease activity appears there. So again, we're taking our short-term endpoints and extrapolating to long-term benefit. So in summary, I think it is certainly possible to show that there can be long-term benefit with advanced therapies based upon surrogates, based upon the typical metrics that we use in our short-term 1-year or 2-year trials. These include disease activity improvement, the attainment of low disease activity states, and for damage prevention, the SDI score, and for lupus nephritis, preservation of GFR. And that's the end of my talk. So I thank you.
Thank you very much. So, yeah, I was thinking it seems like only a few years ago we were saying that lupus trials were so difficult to get right, and now we do the trials quite successfully. but you're telling us we have to start thinking again about different types of endpoints and different types of designs and populations and things. So there's always more challenges. And so I'm going to hand over at this point to our final speaker, which is Chris Edwards. And Chris is going to tell us about how we might implement early treatment strategies in practice and what types of patients they might be appropriate for.
Thank you, Ed, and thanks for including me in this webinar. So there's a few things I'm going to cover. First of all, it's really nice to follow the two talks that have gone before, setting the scene with Guillermo and thinking about the standard of care and some of the failings in that perhaps. And then Richard thinking about some of the newer therapies and the clinical trials. And I guess what we're trying to do is to think, how do we treat people before damage occurs? How do we treat them as early as possible? And we're trying to prevent damage from both glucocorticoids, but also from the disease itself. So I'm going to spend a little bit of time thinking about how in clinical practice we may look at biomarkers that might help us to predict who will do badly, which might help us to justify earlier advanced and targeted therapies. Here are some disclosures. Okay, so let's start with a concept slide. And so this is just thinking about why wouldn't we just do this? We've seen the two talks previously. There's a reasonable evidence base to say we should be treating earlier, we should be reducing the amount of steroid that's used, we should be preventing damage. But there are barriers to this, and a number of them are listed here. So one might be around steroid reliance. So we may be worried about the side effects, but patients often respond, certainly in the short term, to steroids, and so we just leave people on steroids for too long. There are some concerns from some patients, maybe from some colleagues sometimes as well, around some of the drugs we use. I think if drugs are newer, if people have less experience, that might be a concern. And of course, some of the newer therapies, we have to think about scoring people more often. We have to think about assessing them in particular ways. And then depending on how the drug's delivered, they may require different monitoring requirements, different delivery requirements as well. I suppose one of the things we'd really like, and we'll talk a little bit about this, is stratification tools, something that I have in the clinic that allows me to score someone and say, yep, this person, rather than just using my experience or the things that my mentors have taught me, I can put them into this tool and I can say this person is more likely to do badly or more likely to respond to particular targeted therapies, and that would justify their use. And then, of course, over on the left-hand side, there's the access and reimbursement concerns as well. I mean, all countries will have this to differing degrees. Certainly in the UK, that's often a problem. There are some drugs we just can't use at the moment because they haven't gone through the process and they're not reimbursed at the moment. And then, as always with lupus, it's a complicated disease, isn't it? So sometimes we're trying to work out what's the predominant driving force of that disease, what's most likely to happen. To try and predict is not always an easy thing to do. So we'll come back to the barriers and think about how we might overcome some of these things towards the end of the talk. But I thought I'd start with something that is really clinical, and this is just about thinking about the sort of patients who might do badly. And some of this can be determined geographically and from racial group. My biggest learning experience in relation to this was spending time working in Singapore. That's Tan Tock Seng Hospital over on the right-hand side. And I worked with lots of very smart colleagues who were used to looking after very, very sick patients in that environment. And so if we're in clinic and we're trying to decide who should be early, there are certain groups of patients who should be treated early, and Southeast Asian individuals, along with people with black ancestry, come up in many studies as being people who are high risk. I think Guillermo will also tell us about the Latin American experience as well, the South American experience, and there will be populations there that might do particularly badly as well. So sometimes you look at the patient clinically and you say, okay, the demographics of this patient make me concerned they might do worse and might encourage us to use earlier treatment. This slide is just to reinforce this idea, and my colleagues have already shown some of this, around the idea that damage can occur quite early. This is data from London, from David Eisenberg's group, and it's looking at a group of patients followed up over a 25-year period. and looking at the amount of damage at the start, and even after 1 year post-diagnosis, 10% have got some damage, a third by 5 years, and then more than half by 10 years. So people are accruing damage over time, and that leads into this logic of saying if the damage is accruing early, we really should be using the therapies that have been proven to be most effective as early as possible. And often that is a targeted therapy because of the trial data that's been generated to show their efficacy. And that will be increasingly so as we get more and more of these therapies available. Okay, so other ways that we might try and select individuals for early treatment. This is information from the SLIC Inception cohort study, and it's looking at damage. It looks at it in a couple of different ways. First, on the left-hand side, do you start with no damage and start to accrue it, or do you start with a bit of damage already? But the message is really the same, so I won't look at the difference too much. We've talked about race in terms of one of the characteristics that might make us concerned that people will do badly, but there are a number of others that are listed here. So male sex, there was an effect of age, the more disease activity by SLEDAI score, the more glucocorticoid, the more renal use, those things we might think are predictable, and maybe a suggestion of a reduction in that likelihood with the use of antimalarials as well. And then on the right-hand side, we can look at it slightly differently. So that's about damage accrual, but we can look and say, can we look at the things that predict greater use of glucocorticoids and higher doses? Because if we're trying to reduce the amount of steroid we use, we might want to pick out those groups who are most likely to use more steroid. And some of those are around sex, so male sex, more use of higher doses of steroids, different ethnic groups that I've mentioned already, a bit less with antimalarials, and steroids tend to be a bit less over time. And then the more active the disease is, whether that's immunosuppressant use, SLEDAI score, or renal, the more likely you are to have higher doses as well. Another way you might try and weight the likelihood of someone doing badly is to look at classification criteria and look at how many of those different component parts of the classification criteria people have. This is Canadian data. If you look on the left-hand side, you can see the number of individuals in the y-axis, and along the bottom, those are the total number of the component parts of their EULAR-ACR classification criteria. And what they did in this analysis, which is over on the right-hand side, is they divided people with less than 20 or more than 20 of those component parts, and then had a look to see whether if you had more, were you more likely to have problems, whether that's disease activity, that's what AMS is at the top left of the table over on the right-hand side. Did you end up with more steroids? Did you use more immunosuppressants, example? You can see there is lots of statistical significance for that. So you have more diagnostic criteria or classification criteria, you are more likely to do badly over time. So more things you could use clinically to try and determine those individuals. And then I'm going to show you a couple of bits of information which are around using AI to varying degrees. And there are lots of publications like this of various sorts, and I guess this will become clearer how we use this sort of technology. Here's one that's fairly recent, and this is looking at different features, clinical features of individuals, and trying to use that within a machine learning approach, and showing that neurological disorders, the presence of class 3 and class 4 nephritis, and myocarditis, interstitial lung disease, were associated with greater likelihood of damage over time. And I guess we'll fine tune some of this over time. This slide rehearses some of the background to why early treatment matters. Organ damage accrues early, it's often irreversible, so we want to treat people before that occurs. We want to reduce the number of flares, and we want to reduce the amount of steroid exposure. And there's some evidence that earlier targeted treatment can reduce that. So we want to prevent damage and reduce steroid use. Okay, so here's, I'm going to lead into another example with this case. Now, the clinical cases are exactly the same. 32-year-old woman, she's got some symptoms and signs that could fit with lupus, fever, joint pain, stiffness, fatigue, mouth ulcers, some hair thinning. And there's a little bit of inflammation. The ESR is 37 and some lymphopenia. But if you look at the serology, imagine those two scenarios. So you're in the clinic, you're trying to decide how badly someone would do. On the left-hand side, we've got a high ANA, but the anti-double-stranded DNA is negative, but there are anti-SM and anti-RMP antibodies. And over on the right-hand side, there's ANA, but there's anti-double-stranded DNA antibodies present. So which one do you think is likely to be worse? So while I was at St Thomas's and Graham Hughes was taking us around on ward rounds and telling us, he would have pointed to that presence of ANA with anti-SM and anti-RMP in that context being a scarier serological phenotype than having anti-double-stranded DNA antibodies. And so it's really nice when some science sort of supports some of the things that you were taught clinically in the past. So this is some work led by Karen Kostenbader. This is taking 800 plus individuals with lupus and looking at their serology and then using machine learning to put them into clusters. And they developed 4 clusters, which you can see here. And here they are again grouped into their characteristics in terms of the serology. So if you look over on the left-hand side, cluster 1, anti-SM, anti-RMP, those are the people that seem to do badly, along with also cluster 3, anti-phospholipid antibodies, but also the presence of seizures and hypocomplementemia. So within the clinic, these things, I guess, we do from experience and because we've been taught some of this, but it's nice to bring some science to allow us to justify some of those prejudices we have. And I know others have been involved. I know Ed has been involved in work that looked at these sort of characteristics, but also I think clinical characteristics and some perhaps genetic characteristics as well. So there are various people trying to fine tune how we predict how badly someone will do. And I think all of that helps us to have confidence when we use biological therapies or other advanced therapies earlier. So the other thing we might do is just rely on some clinical information. I've mentioned some of these, and some of these may be fairly obvious. People having lots of flares, people having particularly worrying organ involvement, renal, central nervous system, severe hematological involvement, people requiring high-dose steroids. All of these things may allow us to predict clinically that someone will do badly and make us want to treat earlier, as will on the right-hand side, the autoantibody profiles that I've already mentioned, and perhaps even more detailed things like the degree of their interferon signature, for example. But then there might also be other things that would make us want to gain control early. So a woman who wants to conceive, you might want to get control earlier, switch off the disease and create a situation in which it's safer for them to consider a pregnancy. And there might be other reasons around this particular group of individuals, the age they are, work is often an issue as well. So the other thing to look at if we're trying to predict is, and we're trying to justify early use, is also what the guidelines say. So we've looked at some of the guidelines, and I'll look at those in a little bit more detail, but around what they say about early treatment. I think it's fair to say that all of this flurry of recent new guidelines around lupus nephritis and around lupus in general suggest early is good, and there's a move towards more targeted therapy and combinations of therapies as well. And this is driving a desire, being driven partly by a desire for less steroids. So here are the EULAR recommendations once again. And you can see this approach to mild, moderate, severe, the different disease therapies that are being used. And I guess one of the things that this did was shift the use of biological therapies earlier in the whole approach to treatment and into moderate and milder disease than perhaps it had been before. And I think that has definitely created that feeling. There are some statements within the recommendations themselves. So all of these EULAR recommendations start with overarching principles and early diagnosis. We've talked a little bit today about delays in diagnosis being important, and prompt initiation of treatment are important strategies. And of course, these recommendations rely on the evidence base, but they also rely on the opinion of a number of experts when they're being produced. And then this is the more specific one about adding in treatment. And really, I think probably for the first time, although it says, have people on hydroxychloroquine, use steroids if you have to, it gives the opportunity to use biologics without necessarily having to have immunosuppressives first. It hints at that idea that we might be earlier. The more recent ACR lupus recommendations, guidelines, not the renal ones. There are some strong recommendations in there. And of the 3 strong recommendations, one's about hydroxychloroquine, one's about prednisolone, and one was about treatment being early. So another group of rheumatologists feeling this was important. And here's the EULAR lupus kidney recommendations. And if you just look down in the second column, early combination therapy, that approach of using biological therapies and other therapies earlier on, often in combination, and the importance of doing that before damage occurs, before GFR starts to be damaged, as Richard was talking about. Another thing we might do is look at the evidence that comes from people's experience and from the trials around who responds to what therapies. And you might try and develop some sort of approach where you say, okay, I'm going to use different therapies because certain disease characteristics are present. So belimumab in serologically active flare-prone disease, anifrolumab, particularly perhaps in skin disease and where there's an interferon signature. And we know about mycophenolate and belimumab or voclosporin in those with lupus nephritis. B-cell depletion here in many of the recommendations is often put a bit later. In a UK setting, we often use rituximab a bit more, but sometimes that's because we don't have all of the therapies available that we'd like to have. But depending on what the trials have shown, we might choose certain biological therapies or other therapies for certain patients. And then I'm going to show you now a couple of bits of real world data. Some of it was from a few years ago, this study, and then some of it more recent. And this is trying to look at people trying to give treatment a little bit earlier. So this is some data from David Eisenberg's group once again, and this is using rituximab earlier in the disease course of individuals and comparing them to age, sex, and I think disease activity matched controls. So the little black bars are the patients. It's a small number of patients, but it shows them getting their rituximab and treating early, and showing that in those individuals treated early with rituximab, their BILAG score was more likely to reduce. And in those individuals treated early, their prednisolone dose was likely to be less. So some justification when comparing these patients to a control group that earlier treatment might be a useful thing. But this is data this is 14 years ago. And then here's some information from a belimumab trial. This is a Japanese trial from colleagues in Nagasaki, and looking at individuals, and they've divided the patients into those that have had disease for less than 5 years or more than 5 years, and showing a greater reduction in the SLEDAI score for those individuals who had had disease for less than 5 years. So another encouragement to treat individuals early. And then finally, maybe talk a tiny bit about some of the other information we might need to justify the use in the environments we work in, the healthcare environments, the financial environments we work in. This is a paper that Ed, you led on, looking at early intervention. And within it, it's discussing a couple of studies that are looking at how high disease activity can be early, how high the costs can be early in the disease, and also that delays in treatment are common. And some of that information will be important for the health economic justifications we need to be able to treat earlier. Okay, so finally, that's back to the cartoon. So what are the sort of things we might do? Well, we'll collect information from more trials over time, which will help us to know which therapies to use. We might develop better stratification tools that are user-friendly to help us to combine laboratory biomarkers and clinical features to make better decisions. As we learn more, perhaps the patients that we see will be less concerned about some of the therapies. And then there are some practical things on the top left about multidisciplinary team approaches, high-risk clinics, early disease clinics as well, that can help to concentrate the mind around this. In the UK, we spent quite a lot of time setting up regional networks. So we often have discussions from docs across a whole number of different hospitals in any one region. And that can lead to a greater confidence among the group in using treatments earlier. whilst maintaining, good standards and good decision making. So I think there are a number of things we can do, and of course we're trying to taper steroids, worrying about high doses, worrying about medium doses, trying to get down to low doses of steroids, that sort of 5 milligrams or less. So, take home message, damage occurs early. We can personalize a bit. I think in honesty in the clinic, often that's from experience, rather than a really good tool that allows me to say this person will respond. But that's something we want in all our diseases and isn't always easy. I think early SLE clinics, high-risk clinics are practical approaches that sometimes just focus the mind and put that population in front of us and make us think about how we should treat them. Regional connective tissue disease networks works in a UK setting, might not work in different environments. And of course, new recommendations and guidelines are encouraging us because of the evidence base and the expertise of the people within those groups for early treatment. So with that, thank you very much.
Thank you very much, Chris. That's fascinating. And one thing actually that really struck me as you were presenting was that some of those characteristics that tell you someone who's going to do badly, high double-stranded DNA, low complement, high disease activity, they're also the things that always tell us who's going to do the best in a clinical trial, aren't they?
Yeah.
So when those subgroup analyses have been done, they come out with the same things, which does really seem like a real opportunity, doesn't it?
Yeah. They doubly encourages us, doesn't it?
Yeah. It's exact people who benefit. So there's some questions coming in on the Q&A. So there's some interesting ones there that we'll try to get through. But I actually thought of one just to kick us off that I might ask to everyone, which is, including myself, which is, do we actually already do what we're proposing here? In other words, like, are there instances where with a patient at an early point in their disease, maybe at diagnosis or early in their treatment, we've actually given treatments not to treat the disease activity that we see, but in a sort of targeted way because we think that person is at risk of poor outcomes, and we've done something more intensive with a view to prevention. And the reason I thought of it is there was a case in our clinic of exactly that recently, which was a patient who was aged 18 at diagnosis. She had African ancestry. Her only clinical symptom was actually arthritis, but she had double-stranded DNA and Smith antibodies. She had low complement. She had a little bit of protein in her urine, but not enough that I would normally do a biopsy. And my colleagues went in and said, this looks really risky. We think she might develop bad disease. Let's give her early intervention with mycophenolate and rituximab. And she came back and she was completely fine and the proteinuria had gone. And I'm pretty sure we prevented nephritis there by just treating her more aggressively than you normally would have done for somebody with arthritis. And is that something other people, does that resonate? Maybe do you want to answer that first, Chris? Is that
I think there's a tension here, isn't there? There's I want to see disease to treat it, and in lupus sometimes we get mixed up, and disease activity isn't there. People have been over-treated. So there's that tension, isn't there, of not over-treating people and trying to predict too much. But I definitely think there's an element of doing this. If I go back to the talking about that experience in Singapore, people had really bad disease there. In the year I was there, this is one hospital, there were 220 individuals admitted 300 times, and 10 of those young women died. So in that context, it really changed when in that high-risk group with features, autoantibody features that made you concerned. I think you do treat more aggressively. But it is just that careful bit. We've got to be careful to think, we can absolutely predict and treat disease when it's not there. That just makes me a little bit nervous. So there's a tension between those two positions.
What do you think, Guillermo? Do you think that's something that you see happening in practice with?
Yes. Again, I think that what Chris has said is probably more or less what we see in Latin America. It's very common that, as you mentioned it, sometimes we change the treatment from the guidelines by the intuition, by access to care, by adherence to treatment. So, for example, whenever there are guidelines that say that we should start treating with mycophenolate, we see patients in our clinics that they have adherence problems that are not going to be able to reach out our clinics again or so oftenly, and where we change the treatment paradigm, and even with lower dose of with lower proteinurias, we treat them with cyclophosphamide instead of with mycophenolate. So yes, I think there are different characteristics of the patients that tend to guide us in the treatment that we perform.
And then I'll go lastly to Richard. Do you think you see in real world people are making targeted preventative interventions?
No. So I'd be the contrarian. I think it's a concept that we should be striving towards, but I don't know that it happens that often in SLE. But I think in lupus nephritis we're moving a little quicker. I think the trend has been over time to do kidney biopsies with lower amounts of proteinuria. And in fact, Michelle Petrie at the ACR meeting showed some data, patients with anywhere from a UPCR from 0.25 up to 0.5. And, a proportion of those patients had class 2 or class 3 disease as well as class 5 disease. So I think we're certainly moving that way in lupus nephritis, and that would mean earlier recognition and earlier treatment. But for SLE, I don't know. I think it's hard to convince doctors maybe to do so. And I wonder if there are lessons learned from, well, we'd have to go back about 25 years ago in rheumatoid arthritis. We started using TNF inhibitors, but my recollection is we used them for the most aggressive patients. And then the whole, as Guillermo showed, the pyramid was flipped. And so we should be doing that in SLE.
Yeah, I feel like the case to do it in SLE should be better than it is in RA because the potential consequences of getting it wrong are worse, and they do, as Guillermo showed, they kick in early. If things are going to go badly, then they go badly quite quickly. Okay, so let's look at some of the questions in the chat then. So one of the first questions that came in is an interesting one, which is saying, could we, for patients with nephritis, give a combination of mycophenolate and cyclophosphamide at the same time in order to hasten the response, which to my knowledge, I don't think there is really much evidence or experience to say that. Maybe correct me if I'm wrong. But it did make me think of a broader concept, which I might ask to Guillermo, which is, could we, if we want to make early intervention strategies to be more intensive and preventative, do we have to have advanced therapies to do that? Or are there better ways to use the existing therapies in order to do that?
I think that's an excellent question, and I think I will go back to the previous question as well. I know that there's a clinical trial that was from the Chinese that they started using mycophenolate early in the course of the disease. And what they saw is that patients tend to develop less lupus nephritis and less activity by treating patients with low disease activity early in the course of the disease. So in a way, just to answer that, yes, I think that we have to really select the patients, but early treatment with early use of immunosuppressors in some way and without the use of high-cost treatments such as biologics may also change the course of the disease if we treat them early. But yet we need to try to understand which are the patients who are going to benefit the most about these early treatments.
And anyone else want to come in on that one? If not, another question, which I thought someone made a very good point, actually, which is, maybe I'll ask this one to Chris, which is about the strategies to improve early treatment. One point is we need to improve early diagnosis as well.
Yep.
So that's why you can't treat early if you don't diagnose early. And improvement strategies should impact the network between physicians. I think they're talking about things like how people present, referral pathways, things like that, how you get to a diagnosis fast enough.
Yeah, so I agree with the point that's made by the questioner. Um, I think some of these things are very specific to individual countries and the setup and how people get seen. But in general, if you can set up strategies where people are seen earlier and people are seen in clinics where people have an experience in lupus, I think that will be a helpful thing. I think there's also a comment in that question around that differentiation between those people who have undifferentiated connective tissue disease and lupus, and where that tipping point is when you feel confident to make a clinical diagnosis. And I think some of that comes from seeing lots of patients over time. And that's not to say that people can't look after lupus to some degree with smaller numbers of patients and less experience. But in general, the more you see, the better you're going to be at doing this. Yeah, I think that.
And then actually, there's another question that someone's put in the chat, which I think really continues that discussion, which is when we say early disease, what do we actually mean? Is there a time period cut off? Is it less than 5 or more than 5 years? Is it from diagnosis or is it from symptom onset? I mean, I think that's extremely difficult too, isn't
Yeah,
it?
that's a good question.
I I can give I can give the experience that I can give two important experience related to that. One is in level we are working in all Latin America from Mexico to Argentina, performing a study to try to understand what is the delay. As you have said, what is the delay that goes from symptom onset, let's say, to diagnosis, and what delay may will impact on late use of treatment, high dose of steroids use, more damage, more mortality. So in a way, we are trying to understand that, and we are doing a study that it may reflect some of the pathways of the patients, the clinical pathway of the patients, and the story of the patients in Latin America that may reflect what happens in other parts of the world. And another thing that is, I think, is quite interesting from the SLEEK group that is working with Africa, that is highly related with this, with the presence of autoantibodies and what is delay. It's a study that is being done by CIFA-DEY in Africa, where the problem that they have to make an early diagnosis is that, for example, in Ghana and in some of the countries of Africa, they have less than 10 rheumatologists for the whole country. So in a way, education, I think, close work with primary care physicians for early referral. I think those are some of the pathways that we have to work, and projects like this, early education on physician, I think it's quite important to narrow this gap of delay in diagnosis.
Yeah, and in those environments, Guillermo, it's really important that it won't be rheumatologists always making the diagnosis or try. It will be internal medicine physicians, it will be primary care physicians, it will be health visitors, and them having some idea that these might be the characteristics that point them in the direction. Just coming back to the when is early disease early disease? I think it is just like the rheumatoid arthritis discussion. I mean, people did studies years ago where they just went early meaning less than 5 years, early meaning less than 3 years, and then they did a very early and very, very early. I don't think it matters exactly where we call it. I think it's just a direction of travel that says let's do studies where they're earlier, and it will start with 5 years because it's just that's easy and we'll manage to recruit. And then as we get better at it, we'll fine tune it earlier and earlier. Presumably, conceptually, that we might be able to define immunologically periods of time that are early in a different way, where people might respond to therapy more. And then in other inflammatory diseases, there is some fascinating work around functional MRI scans saying the effect of inflammation creates changes, and those changes may then stay even when we control the inflammation. And so it becomes another reason to treat early, because those might be part of what contributes to brain fog and some of the cognitive dysfunction that our patients have as well.
You can make
Yeah,
things
and
even more
there's another thing.
complicated.
I've been saying it all the time recently, but and maybe even on one of these webinars before. But I think we talk about we want to prevent organ involvement and damage, but we measure by things like SLIC. damage index and stuff like that.
Mm.
But when I've seen a lot, and now I'm old enough to have seen a lot of patients through the whole of their journey, basically, and I think there's something else that happens in SLE, which I call to myself like social damage, which is basically like if you're young and you're suddenly diagnosed with a chronic disease, it's a new life. And you might spend the whole of your 20s kind of being a bit ill, not super sick, but a bit ill. And it means that you don't have the relationships you wanted, or the family you wanted, or the career you wanted, and things like that. And all of these are things that you can't get back with better treatments if they're given down the line. It's gone. Those are sort of life opportunities that have passed. And isn't that a kind of damage too? An irreversible impact to your life. And that's another reason maybe why earlier treatment could be beneficial.
Yeah, so how early is early gets even more complicated if you go back, about 23 years? The iconic paper by Arbuckle,
Yeah.
Yeah.
telling us
Yeah.
that the disease starts before the disease starts, meaning you have immunologic aberrations many years before clinical onset of disease. So you could somehow, figure out who's destined and what the trajectory of their conditions will be. And Ed, actually, you published on that, the transition from incomplete to complete lupus, and you
Yeah.
intervene with hydroxychloroquine.
Yeah. So yeah, of course the hydroxychloroquine study wasn't that was presented recently wasn't mine, but yeah, I've published on the early phase. And actually, we learned something doing that study. So we set up years ago these at-risk clinics. The idea was anybody who's referred from primary care with a positive ANA can go into this clinic so that we do a research study on them and look for who's progressing and what happens. And that we learned lots from doing it. But one interesting thing I learned was that even though we had the most open door possible, which is, just come with your positive ANA, you'll get an appointment with a research fellow next week. Even all the time we were running that clinic, we were still getting people diagnosed with SLA on the intensive care unit. And as an inpatient, because they somehow avoided that, they presented in some atypical way, or they hadn't engaged with health services or something like that. So it's hard, even when you think you have made it as frictionless as possible. And then another thing that I'd learned, I read another study that was done on a primary care database, and what one thing that was shown was that people who got a diagnosis of SLE, if you look at their primary care records leading up to that diagnosis of SLE, people just start going for years before, they just start going to see primary care more often with a whole variety of things, some of which didn't really appear to be lupus, but you could just see that things were kind of getting more complicated and difficult in their health up to the time when they were diagnosed with lupus, which is sort of a fascinating finding, really.
Yeah, the early intervention study with hydroxychloroquine was a SMILE study. We participated in that. So a negative outcome, but maybe just a longer period of time, more patients. I don't
Yeah,
know the downfall of that study, but we'll
it's
see.
difficult, and that leads me to a question I was going to ask you actually, which is so I'm going to ask this for slightly selfish reasons actually, which is I think you showed us some of the things we need to look at in the trials, and basically for early intervention, it's not just response, is it? It's not just SRI4 that might be appropriate now. It might be different kinds of endpoints that we need to do in someone with evolving disease that might be worsening. So, what would an ideal trial look like if you wanted to do a trial of an advanced therapy specifically to look at early disease? And the reason it's selfish is I'm trying to do that trial. I'm trying to design such a trial
Oh, then you
myself.
tell
So
me. You don't put me on the spot.
I want some advice.
Tell me your design and let's critique it.
Okay, I'll tell you what we're doing. So we're doing a trial in the UK called First, and it's about first line rituximab at the point of diagnosis of lupus. We decided not quite at diagnosis for exactly the reasons you've said. It's hard to say when the diagnosis really occurs and when symptoms started. So we decided to say, let's do it when they need to start immunosuppression. So once you sort of say this person now needs above antimalarials, that's the entry point at which you'll get randomized to conventional therapy, meaning azathioprine, methotrexate, etc., or that same therapy plus rituximab. And what we decided to do was that response wasn't really going to work because people would still have, they might not have got to their worst yet. You might be trying to prevent worsening as much as improvement. So what we decided to do was a kind of time on target endpoint. In other words, how many months are you in LL-DAS out of 12 months? Like, is it what we work out with a mean of 6 in this group and 8 in that group or something like that? I'm putting you on the spot now.
Yeah, so let me ask you about some of the statistics. Sample
Yeah.
size, what was your estimate on effect size between the two groups?
That's exactly, well, you've exactly hit on one of the most difficult things, but there was very little background data to do it from. So what we did was we used some of the estimates from the other clinical trials, the placebo arms of trials that have published that kind of stuff about what on conventional therapy, how long people get in LLDAS. But yeah, that was one of the hard parts. Yeah.
And how long will this trial go on?
They're getting 12 months of follow-up, which is probably shorter than I would like.
Yeah, that's what I was
Uh,
going to say. That may be too
yeah,
short.
yeah. But you've got to start somewhere, haven't you?
True.
Yeah.
Let me show a question. What about the trial without the use of oral steroids?
A bit like the Rituxaloop style
Mhm.
trial. Yes, that's right. That would be another one. I mean, you try to minimize steroid use, wouldn't you? And I guess one of the challenges there is that you need treatments that don't just work, they work fast.
Fast.
Place the steroids, don't they? Like avacopan does for ANCA vasculitis. If you're going to replace the steroids, you need something that works quickly. Um, I'm just looking at some other questions in the chat here. Um,
There's a quick one about hydroxychloroquine while you're looking about, it's a
yeah,
question of can you ever stop? Well, lupus doctors rarely stop hydroxychloroquine, I think. But you do sometimes, don't you? If people have had disease for a long time, uh, in a woman that developed a disease in her 30s and now she's 60 and her disease is quieter, and as is often the case, then sometimes you do manage to stop all treatments. But we're all very cautious, aren't we? We're very slow to take it away unless there's a problem
yeah.
with it. I don't know if anyone feels differently.
I think it's very difficult generally to know when to stop treatments.
So I
In
check
the
hydroxychloroquine levels every 3 months on my patients. What is your practice in England and down in South America? Do you check the levels?
Yeah, I don't. I've never done. I've seen the data presented by various people, Richard, but you find it useful?
I do. I mean, it's kind of like Natalie told us 20 years ago, patients don't take their medicines.
Yeah.
So that's
So is
one
it compli
cluster.
so yeah, so one is compliance, yeah.
And then another is, I think the 5 milligrams per kilogram, you're underdosing patients on average.
Yeah.
And
So
then,
I think you can learn a lot. It's a rare patient that has over 1,000 nanograms per ml, which is the target.
Mm,
But getting to the patient where you might discontinue or maybe not be as aggressive and settle for, a level of whatever, 600, 700 nanograms per
mm,
ml. I might do that rather than just stop.
and then
okay.
what one other question I was just thinking about, Chris raised it. Perhaps I'll ask this to Guillermo first. Is one of the challenges I think in all of these early intervention strategies is the patient's acceptance of it, and then that that can be quite difficult. That you're explaining to them something about it's not how you feel today, it's how you might be in 1 year, and patients often want to start off with a little bit of treatment and only build up to the other treatments if they they feel they're not doing well and things like that. I wonder what's your experience? How do you approach that?
In First, I will try to answer what Richard said. We don't have access to hydroxychloroquine levels in South America. I don't think that in any of the countries from Mexico to Argentina we don't have access, and that's a pity because yes, as Richard said, I probably the 5 milligrams per kilo, and mostly in mestizos patients, most of the time seems to be like we are not getting enough medication. And then discussing with patients about treatment, it's very difficult. It's very difficult, and it may change a lot from consult to consult, from the place where you practice. If you are practicing in a public hospital, some places in Latin America, or if you are doing in a private institution, education of the patients is totally different. And as you said, it's hard for some patients to try to understand what you are thinking in the next future in order to prevent damage and to explain then damage. So most of the time, what we do is we have what is called hablemos de lupus. Let's talk about lupus. That is a program that we have launched in Latin America in a way for patients to try to build their own stories and share it with our patients, also with the people taking care of lupus patients. And usually this helps a lot for patients to have a better adherence and to try to work more with questions and answer with the physician. These are some of the strategies that we use.
Yeah, I agree. Because I find, at the point of diagnosis of lupus, it's quite challenging information overload, isn't it? Because these are always people who are not used to being ill. They're young, they're not experienced with going to clinics and seeing doctors. And suddenly you're telling them that they've got a disease that they're going to have forever. Also, it's a disease that confuses doctors, never mind a disease that confuses patients. And it sounds potentially quite scary when you start reading about it. And usually my approach when at the time I diagnose people is kind of to try and be quite confident, like I can get this better, don't worry, we've got good treatments now. There's lots we can do. And it's how to weave in information about, but things might get worse. And these other terrible things could happen to you if we don't make the right moves. It's challenging, isn't it?
Yeah, I tell you the thing that makes people want to go on earlier treatment though, it's them knowing that they're going to be on less steroid. Often people will say that straight away. I'll go on that if I don't have to be on steroids, doc. Steroids
Yeah.
really worry people for lots, but lots of young women are worried by being on steroids.
Yeah, that's right. Yeah. And I suppose treatments that have good evidence base, again, will also be, I think you just want to give people confidence, don't you? That's always my approach. So at that point, I think unfortunately we could probably talk for ages, but we're pretty much out of time. So thanks everyone very much for attending. Thank you to all our speakers for these really excellent talks and discussions. And I'd just like to remind everybody, if you could please try to fill in this short evaluation form that'll just come at the end of this webinar to let us know your feedback. As I always say, we really do look at it and think about what we're going to plan. We're looking at what our 2026 activities on Lupus Forum are going to be right now. So that will be very timely and useful to us. Again, if there's the live streamed version of this webinar is going to be available on our YouTube channel and on the Lupus Forum website. So if you've got colleagues who might be interested who weren't able to join, you can direct them to go and have a look at that and they can catch up on all of this. And I'd just like to thank BMS for supporting this program with an unrestricted grant. BMS funded this webinar but had no influence on the content of these presentations. And with that, it just remains for me to say thank you to everyone for your attention, and we'll see you next time.